Come on, the little gerbils are doing the things. Wow, good evening. Welcome to CPD Me webinar, Tuesday the 4th of July. My name is Andrew Ormerod and I will be facilitating tonight, and I will very shortly be handing you over to the fabulous Jamie Todd, talking all things ultrasound pre-hospital. So, oh gosh, Jamie, you were quicker than Carmen. You were got in there before Carmen. Carmen is always the very top of our chat, and you got in there quicker than Carmen. I'm sorry, Carmen. So, great to have you on board tonight. Lots and lots of people registered. Fabulous for a Tuesday night of learning. At the bottom of your screen, you will have several options. You have a chat option that Jamie, Carmen, Daryl, Caroline, Carmen, and Yomi. It's raining in London. Where is summer? That's a good question, but my grass is loving this wetness. Lisa from York, Jen, who's a sonographer from North Yorkshire, Tony, who's Stoke-on-Trent. Great to have you on board, Tony. Nice to see you. Robert, who's west of Ireland. So, in the chat, tell us where you're dialing in from tonight. Maybe tell us what you do for a living. And in the questions and answers box is where you can put all the Q&A for Jamie. And I've already seen you can find the emoji button, so you can send some little love hearts. You can do a little thumbs up. You can clap, a round of applause, and you can also fire a confetti cannon if you feel the need to do so. James, Cardiff paramedic, great to have you on board. Mark, who's an ED SPR from Preston, great to have you on board, Mark. Not very far. In fact, we're almost at fingertips, Mark, from Preston. We're not very far away from you. Jamie, who's a student paramedic from Blackpool, great to have you on board. Jordan, Sam and Jordan, nurse associates, great to have you on board, both of you. Sharing one, I like that, sharing one. The problem is only one of you will get a certificate if you remember. That's the issue with sharing. But sharing is caring, isn't it, always? Kathy, who's a Trinidad pharmacist. Great to have you on board. Trinidad, that's a long way away from Preston. And Liam, who's a Northern Ireland medic in Cave Rescue. Fabulous. Lots of fabulous people on board. Tatiana, who's an ODP from Harpenden. I don't know where Harpenden is. I should have learned better when I was I should have sat at the front of the class in geography rather than at the back of the class. It was terrible. Right, let me get my presentation up and we'll get this show on the road. So hopefully you will be able to see my screen now. So give me a little thumbs up if you can see my screen. Perfectly. Fabulous. So we can't see or hear you. So if you are sat there in your dressing gown or you've just come out of the shower and you are drip drying next to your radiator, don't worry, we can't see you. And if you're equally eating crisps or nuts, we can't hear you munching and crunching. So you don't need to worry about your mic and your camera. Questions in the Q&A box. And of course, if you are a premium member of CPD tonight, you will get a CPD certificate that will come to you in the morning once Fabio's had his espresso. So that's around about 11 o'clock. Normally he's at about 2 by then. And of course, that will automatically come to your email inbox and also drop automatically into our CPD system so that you can make reflecting, recording and managing your CPD super simple. So if you're not a member of CPD and you are a paramedic, we are just about closing the HCPC window, but I can tell you we have had around 200 paramedics this month who have used CPD to capture their CPD for the HCPC, because we have a very specific CPD portal that allows you to extract all of your learning and development into a perfect format that then takes all the pressure and stress away from audit. But it only works, of course, if you put all the CPD into the system. But what the system will do is help and support you along the way. And we've got some amazing new functionality and features coming, like the CPD health check in the next couple of weeks that will scan all of your CPD with some artificial intelligence and give you some top tips to fill gaps, support learning, add more evidence, and everything else that goes with it. So $17.99 per year, you get access to 400 recordings, 80 live webinars. Next year, we have just planned 140 live webinars for next year. But there will be a price increase, because to provide 140 webinars means 140 speakers, means 140 facilitators, means 140 hours, means a lot of time and effort. So, but we will literally have 3 to 4 live broadcasts per week covering every subject you could ever imagine, as I was just chatting to Jamie about before we started. So definitely not something to miss out on, but you can fix that. Cheapest chips cost $17.99 per year, and I think it's only gone up to £24 off the top of my head. But as I said, you get literally 100 plus live webinars, which is just like liquid gold. So fix that pricing now. I guarantee you, then at least you've got that for the next 12 months. 7 good reasons. Of course, it makes CPD recording simple, and you can use our mobile app, which again has got 4 new features that are launching at the end of this week, in fact. So we are probably one of the very few CPD systems out there that make sure that we've always got a system fit for practice. So this week we've got 4 new functions and features that you've now put me under pressure. I can't remember what they are, but I know one of them is tagging, portfolio building, and something else in the app. So lots of great new features and some automated notifications around gaps, I think, is coming in the app. So, but lots of good reasons there to join CPDME. You don't need me to read them all out to you. And anybody who's online who is a premium member will tell you it's probably the best 17 quid they've ever spent, because it's per year, not per month. People think it's monthly, but it's not. It's one payment per year. Always good to get social with us. So please do tag us on Twitter, on Instagram, Facebook, and on TikTok. And if you do copy us in with your relaxed learning style tonight, maybe a picture of your screen, maybe a picture of you with your animals, maybe a picture of you with your can of pop, whatever that might be, but tag us in with hashtag CPD Made Simple. And I will, of course, make sure that we will either send you one of our CPDME mugs with the QR code for the webinars, or one of our CPDME USB chargers. So please make sure you get social with us if you get a few minutes tonight. And I will make sure tonight, when I'm having my bath with my lavender soak around 10 o'clock, I will look for people who have tagged us, and then I will direct message you and say, send us your address, and we'll send you some goodies. I think I'm going to get sacked. I think somebody's trying to replace me, Jamie. This slide makes me exceptionally nervous, but I'm wondering whether it's because we're increasing webinars and they don't want me in the office 4 or 5 nights a week. But we are looking for a replacement for me, or some additions for me, actually. We're actually looking for 6 people. So if you fancy doing what I do, which is dead simple, if you just do it enough, it just becomes natural and normal, and you can just be yourself anyway. But if you fancy that, there's exceptionally good rates of pay, and all you need to do is just email the team at cpdme.com with an expression of interest email, and we'll be doing some auditions, which will be like, in fact, we should probably go live and do the auditions in front of a live audience. What do you think? Thumbs up? Do you think we should have a live audition for facilitating webinars? I think that would be quite an entertaining evening, if nothing else. You won't learn anything, but if nothing, it'll be quite an entertaining evening for us. So if you fancy it, drop us an email. Couple of events before we get started. We are just confirmed that we have sponsored the Faculty of Pre-Hospital Care Conference 2023, Monday the 6th, Tuesday the 7th of November. That's up in Edinburgh. CPDME has just become their main sponsor, so we will be there. And of course, if you have any questions or queries or anything else CPD related, come and see us, because it's always good to put a face to a name, and we'll have lots of goodies to give away. So please jump over to cpdme.com/FPHCC conference or 2023, or just Google search the Faculty of Pre-Hospital Care, scan that QR code and grab your ticket. But we will definitely see you there. And we're also sponsoring another amazing event in Cardiff. And I always want to put a Cardiff accent on when I say Cardiff, and I'm not very good at it. So 27th of March 2024, and that is aimed at all pre-hospital practitioners. And I think it's only about 25 quid a ticket. So again, scan that QR code or jump over there, and I will make sure that I post these on social media. So if you want to catch up with them later, you can do so. And then the last event is our masterclass on the 5th of August, covering all things major incident and disasters. So again, members £4.99, non-members £9.99, cheap as chips, and it will cover a plethora of exciting topics and subjects by a leading lineup of professionals. And again, it's one of Dr. Linda Dykes' symposiums, but it will definitely be good. I think we've already sold about 400 tickets, so definitely worthwhile. And then last but not least, before we get underway, if you are a student, then CPDME is completely free to use, but you must use your student email address to register. So please use your student email address and you will get 2 years free membership. And if you are a student and you are on a student WhatsApp group, snap that screen now with your phone and put it on your WhatsApp group, because it's probably going to close at the end of September, because we've already filled our quota for this year. So it's a good opportunity to get your colleagues and your peers to get on board and join tonight. All that leaves me to do now, Jamie, is hand over to you. So I'm done talking, and hopefully you're good to go.
Thank you, Andrew. That's an excellent start, as ever, And yeah, good evening, everyone, and welcome to this evening's webinar on could ultrasound in pre-hospital care become a routine tool? So just let me go in here and share my screen. I think there's a question for you there, Andrew, in the question box while you're looking. Can everyone see my screen okay?
Perfect.
Oh, we're getting some thumbs up there. That's lovely. So good evening and welcome from rainy Hampshire here to this evening's webinar on ultrasound use in pre-hospital care. If you can see the opening slide there, we see ultrasound being used in the back of an ambulance. Now, we're going to start early with a small competition. If anyone can tell me, so it looks like from that picture, they're doing a ultrasound of the chest. I think you can just see looking at the pleura in the on the little screen there they're using on the phone that's linked to the V-Scan Air probe. If anyone can tell me what's wrong with that picture, if you're familiar with the V-Scan Air, I'll get Andrew to send you a prize. Small prize from his mass collection, from his cupboards of prizes. So yeah, just pop that in the question box if anyone knows the right answer. It's a technical answer, so you need to know the device itself. So let's see where this evening takes us. I noticed it about the picture only yesterday when I was just a random picture I picked off the internet. So let's see where this is going to take us this evening. So, you know, the question we're asking this evening, amongst about what's the utility of ultrasound in pre-hospital care, is also, could it be the future? Yeah. And let's have a look now. Matthew Turner, you are the winner of the competition. Don't know who you are without clicking on you. Hold on, let's see if that works. Yeah, send Andrew a message, he'll send you a prize. Matthew Turner's the winner of the competition. He got in first. If you're using the V-Scan Air on lung scan mode, they're using the wrong end of the probe because it would use the curvilinear end automatically. So good spot. We've got some people in here that know something about V-Scan Airs. Excellent. A few people got it as well. So yeah, quite a few people got that right. Excellent work. But Matthew Turner, you were there first. So why not? You know, why can't it be a routine tool? So there's a few questions we have to ask, and what we have to do partly is look at history and other things that have become standard and other things that we do. So there is no limitation on the future. There's no defined limit scope of practice for paramedics like many other healthcare professionals. Nothing says, you can do this as a paramedic, you can't do this. There's no limit on our practice like that in the UK. If you look at the HCPC standards, it defines the scope of practice as the limit of knowledge, skills, and experience the individual possesses in relation to their professional role and the enactment of that lawfully, safely, and effectively. And nowhere it defines what you can or cannot do. So, being a paramedic is not a limitation. So this talk is about utility and where we could use such a thing, in routine practice. But the first question we need to ask is why not? What would stop us doing so? So we're going to look at some other medical devices out of interest. So on the left there is the original stethoscope from circa 1816. Yeah, which is about when Andrew was born, or was that when he joined the ambulance service? I can't remember. Yeah, but about 1816, the first stethoscope. And that has obviously evolved tremendously over time, but it's probably, with the exception of the fancy thing I found there, which I'm not entirely sure what it does, has been essentially unchanged for years. Once we changed to the sort of things in your ears and the thing on the chest sort of end of auscultation, they're fairly much an unchanged device, apart from some for people with limited hearing that have got, amplifiers in or whatever. But they've been around for a really, really long time. Ultrasound is sometimes described as the stethoscope of the future, the replacement for the stethoscope, because it enables us not just to listen inside the patient, but look inside the patient. And, these are some of the problems we have with stethoscope use. Firstly, noise. A lot of times we want to listen to someone's chest, particularly in trauma and so on. Someone's parked 6 fire trucks by us, which are noisy by default, because so you can't hear a thing. And you're next to the side of a busy motorway or something like that. There's a lot of background noise. In reality, you can't even hear yourself think, much less, listen to a stethoscope. And another problem, of course, might be stethoscope quality. The Fisher-Price stethoscope on the right there is something like that the NHS buys, the sort of $199 NHS supplied stethoscope that, frankly, you probably couldn't hear a train coming through, much less anything else important. So that creates an issue as well. And then practice, how much do we get to auscultate people's chests? How many people with, abnormal chest noises do we hear? So there's a whole skill in that. We don't really get to practice that much because you don't get to see those patients. So we use it in a very blunt way most of the time. So that's sort of, stethoscopes have been around for a really long time. What next? Well, pulse oximetry. So the original pulse oximeter was designed in World War II and was used in aviation studies. The first commercial devices came out about 1972. So when I was joining the ambulance service in 1994, it was first starting to appear on ambulances, but wasn't everywhere. So yeah, it was a considerable time for it appeared on ambulances. So we've gone from something that, was a massive box and interestingly an ear probe, that was the original pulse oximeter there, using an ear probe, to the finger probes we're used to, in tiny devices. And once, if you've got a rainbow probe, for example, you can also measure carboxyhemoglobin and methemoglobin as well, amongst other things. So, a massive step forwards. But again, there's a number of problems with pulse oximetry. All the things we know about normally, that stop the accuracy of pulse oximetry. And, even the most expensive probes, the Massimo ones, their own standard is it's only accurate to within 2 digits. So 94 could be 92 or 96 in a well-perfused person, or 3 digits in a poorly perfused person. And obviously, if it's a $9.99 pulse oximeter you bought off eBay from China, it probably doesn't mean anything at all. Now, a bit like ultrasound, if you're using a tool, it's very important in medicine to understand how that tool works a little bit, because unless you have some knowledge about how the thing works, you don't know whether it's working properly or not, and how likely it is to be accurate or not. And that applies to many things we use, like non-invasive BP, pulse oximetry, tympanic thermometers, blood glucose meters, and ultrasound. You have to know a little bit about them to know whether they're working properly and to be able to utilize them properly. So I found a really good video. Say pulse oximetry could be a talk in itself, but I found a really good video there, put it up for you. So if you follow that QR code, it'll take you to a very nerdy man, not me, with a whole video about how pulse oximeters work. And that's really useful because it tells you, also when they won't work and when we should rely on them or not. One of the biggest things I think that isn't mentioned much, it mentions their anemia and whatever. Remember, they only measure the hemoglobin saturation on the hemoglobins it can see. It doesn't tell you how many hemoglobin you've got. What about defibrillators? Defibrillators only appeared on ambulances probably in the 80s. Yeah, this is the first portable defibrillator from 1965 from Dr. Pantridge. Yeah, on the left there, used car batteries to create enough energy to power the device. And it weighed about 70 kilos, so about the same as the LifePak 15. And the one on the right, obviously, the most, modern device, the cell AED that's just starting to come out now, where it's a disposable defibrillator where you can twist the thing, open it, and apply the pads to people. Yeah, so, technology has moved on considerably. We didn't used to have defibrillators on ambulances. If you told someone in the 1970s we're going to have defibrillators on ambulance, they would have said you were mad. Yeah, and now you can buy one off the internet and break it in half and use it because it's disposable. Yeah, so we should never say never about devices. And if we're going to trump that in its entirety, then what about CT scanners? Yeah, first invented in circa 1967 and first used on a live patient in 1971, a British invention. And the Norwegians have an ongoing project to see if it's technically possible to fit a CT scanner into a H145 helicopter, because they have, in the northern area of Norway, very few hospitals and very few CT scanners for the super rural area. So effectively it would be a stroke assessment unit to be able to assess patients rather than taking them hundreds of miles to the nearest CT scanner. Not in operation, but a feasibility study they're doing with a manufacturer of CT machines to see if it's possible. And not just the small head CT scanners that some places have got running in mobile stroke ambulances, recognizing the limitations and the studies that don't really support sort of thrombolysis through those routes. But yeah, technically what is possible increases all the time. So where will it end? You know, is there an end to it? Well, probably not. To the left, if you're a Star Trek nerd, yeah, if you want to dress up and go to conferences and that sort of stuff. I went to a show at the NEC, and the hall next door was the Star Trek conference. It was most enlightening. But that's a Star Trek tricorder, which has been in the movies ever since the very start, a sort of a handheld scanner for all medical things. But in reality, how far are we away from that? Some of our most advanced monitors, like the Zoll X Series Advanced on the right there, ready for the list. This has in it ECG, 12-lead ECG, SpO2, SpCO, SpMet, end-tidal, NIBP, invasive blood pressure, defib, pacing, cardioversion, external, internal temperature, CPR feedback, ventilation feedback, and more in something that's hand portable. So if you look at some of the other Tempus Pro sort of monitor device, that can also have video laryngoscopy and ultrasound built into it as well. So how close are we to inventing some very small multi-purpose scanner like the Star Trek tricorder? I suspect not a million miles away. It's just a matter of miniaturization. I think we have these people that have external glucose monitors and all this sort of stuff. This stuff is the technology is advancing all the time, and we can't ignore that. Otherwise, we're going back to the people in the 1970s that say we'll never have defibrillators on ambulances. So what about ultrasound? Where does that come from? So a little bit about sort of the first ultrasound science. So the idea of using effectively radio waves, sound waves as they are, to measure stuff. The first ultrasound science was recorded in 1794, which is definitely before Andrew joined the ambulance service. Yeah, so a really, really long time ago. First medical use circa about 1956. It was hard to pin down an exactly correct answer, but mid 1950s, it was start to be used for scanning in maternity cases. Yeah, so been around for quite a long time. Yeah, and this is for the original machine, as you can see, obviously enormous. And he's got a white coat on, so he's a very serious scientist. But now relatively cheap and portable with ever increasing quality and utility. And to the right there, we've got a picture of sort of the most common sort of handheld ultrasound units, which increasingly get more impressive by quality and better software, enable them to do more and more and more. They're never at the moment going to meet the standard of a sort of hospital unit where you've got the much better quality screen, etc. But they're really quite impressive now compared to the early handheld units. There's a little bit about history, and what that part is about is why not? Yeah, if we say we never would have had any of these other things on ambulances and now we do, we're not now just going to stop and go, well, I'm quite happy with the technology on my ambulance, I don't want it anymore. Yeah, there's no reason why things like ultrasound and future technology and CT scanners and everything else can't end up in an ambulance, because it's technologically possible and history would tell us that it probably will happen. So when could we use our ultrasound in pre-hospital care? I said this talk isn't specifically about the skill of ultrasound, but we're going to cover some of the uses of it. So what we're doing is trying to raise some sort of awareness of how it could be used. So there's ways it could be used fairly routinely, and we see those used by critical care teams and critical care paramedics and others in pre-hospital care today. But could those become more routine to replace our sort of stethoscope and other such tools from the past? So most commonly in trauma are sort of EFAST type exam, using our probe to look at different areas of the body, looking for particular abnormalities. So it's quite didactic, and we're looking for certain things that may or may not be evidence of something being wrong. And we'll talk about later how we use that information as part of a bigger clinical picture. So our EFAST exam is the most common, extended focused assessment by technically sonography and trauma. So in shortened EFAST. How can we use that in our decision-making model? Well, certainly in our lung side, we can rule in and rule out pneumothorax, by seeing not the air, because we can't see inside the lung because the ultrasound beam doesn't travel through air, it scatters it. The way we describe it when we're teaching ultrasound is like shining a torch on a disco ball. When you shine your ultrasound beam into something that's full of air, it just scatters the beam in all directions and create this mush, which only changes if there's a lot of fluid in there, which there probably shouldn't be in the lungs. That's a different sign in itself. But what we can see is the lungs sliding. We can see the pleura. We're going to see an example of that in a minute. So it can help us rule in and rule out pneumothorax. It can help us rule in hemothorax. Although in reality, if we see fluid in the bottom of the lung, we can only say that it's fluid because ultrasound sees all fluid as black. It can't tell you whether it's blood or other fluid. But how we differentiate that is through what's happened to the patient. So if they've just been hit by a lorry and they're not breathing very well and there's a lot of black in the bottom of their lungs, then it's probably blood. But we couldn't 100% say that. It just seems very likely. We can rule in cardiac tamponade. We can see the effect of it, see it around the heart, see the effect it has on the heart. And we can rule out there's other pericardial fluid. But again, we couldn't say what the fluid was, whether it was pericardial effusion or blood forming a tamponade around the heart, but we can see the effect of it. And in the abdomen, we can see free fluid where it's not supposed to be, and the same looking down into the pelvis. So if we see that, we know that's abnormal and it shouldn't be there. What we can't do is rule it out very easily because it hides itself behind all the organs, and the abdomen's a very complex thing. It depends which way up the patient is and so on, where the blood will collect. There's some common places where it will collect. But all we can say is we haven't seen it. We can't rule it out because it could be hidden. And in patients that are slightly larger around the middle, that can be more difficult. So let's see some examples of these that sort of help us see some of the images we might see. So here we have, if we've got someone looking at utility, here we've got someone with some, impressive seatbelt marking, which I accept probably isn't instantaneous. This is, been a bit later when all the bruising's come out. We go to these patients quite a lot, don't we? Patients that have, general tenderness across the chest. There's no obvious fractures, but everything's really being sore, or they have got some fractures and it hurts when they breathe. Then we're interested in whether there's any other, but otherwise all their obs are relatively okay. And we're interested in whether there's any sort of obvious underlying injury that's hiding from us, particularly in our young people, that are super compensators and hide things well. And I've been to a couple of patients like this in the last few days with chest injuries and rib fractures. And one of the problems is they're quite difficult to assess using standard methods. If you've got rib fractures, we know it hurts like a bugger. And so these patients, intentionally, due to their pain, limit their respiration. They breathe very shallowly, and they can be really hard to auscultate and really hard sometimes even to see meaningful chest rise to tell one side from the other. When it's so painful, they're breathing very, very shallowly. But not in respiratory distress because they don't appear to have any underlying problem. So obviously analgesia is a massive help there, but also ultrasound can be useful because we can determine whether there's lung sliding underneath, and that may reassure us or not as to whether there's underlying injury. So the picture we're seeing to the right there is looking between the ribs. The black columns you see either side are the ribs because the ultrasound beam can't travel through the dense bone. So we just see shadow behind them. And in between, we see the look into the lungs. So lower down, you see the mush, which is the air scatter. And we see a white line there between the ribs, and that's the pleura. And that's the effect we're looking for. So we describe it as ants running up and down the line. up and down that white line, we're seeing movements. What we're seeing is the two pleura sliding over each other. Yeah, we're seeing the motion of the pleura, and that's telling us we have lung sliding. We can do that right down the chest and determine where we have lung sliding. That's one of the uses we might use it for. We roll on a little bit. I see a questions come in, but we'll come back to that one. Yeah, our sort of cardiac scan. Yeah, we've got a patient, with trauma to the chest. Probably not as dramatic as our Deadpool cartoon there. Yeah, but and one thing we'll talk about later is when it's appropriate to use ultrasound or not. If you've got a patient who's clearly really sick, and you just and you've got a suspicion why, then ultrasound may not be helpful unless you can do something about it right now. Yeah, so it's not always a benefit. We're not always going to scan things. So what we're seeing here is cardiac tamponade. Yeah, the bit at the bottom where you can see the heart beating away quite happily, and then the sort of white ring around the top there is the pericardium, and this big black area here where the arrow's pointing shouldn't be there. Yeah, that's a lot of free fluid outside the heart. Yeah, but inside the sac. And obviously, the more there is there, the more it's going to compress the heart and reduce cardiac output. And we'll see the effects of that in the ultrasound, as well as the effects we might see in the patient. So that sometimes might be useful. Could be trauma, but it could be a medical patient where you've got pericardial effusion, but may have a place. In our sort of general blunt trauma patients, someone who's come off a motorbike or being involved in a very high-speed collision or something like that, has abdominal tenderness, generalized abdominal tenderness, and again, in a young person, maybe reasonable, passable observations, and they're just a bit sore, and you're not sure what's going on, then it is possible to scan the abdomen. We're looking at the left and right upper quadrants of the abdomen, where blood tends to trap either between the liver and the kidney, or in this case, what we're seeing is up above the spleen in the right quadrant. So we can see the diaphragm moving up and down, and we can see the spleen, and that spleen should be pressed up against the diaphragm. But what we're seeing there, that black shape, is free fluid in the abdomen trapped between the diaphragm and the spleen. One of the ways we can see it, it's black, so we know it's fluid, and its weird shape gives away the fact that it's in the wrong place, because nearly everything in the human being is round where fluid should be contained. So any angulated fluid is commonly abnormal. It's fluid where it shouldn't be. Again, we can't determine what that fluid would be, but our sort of clinical perspective of the incident, may be the thing that gives it away. Maybe in the pelvis. I think that's the most impressive picture of an open book pelvis I managed to find on the internet. Yeah, so probably don't need ultrasound to tell us that guy's got a pelvic fracture. Yeah, but looking down towards the bladder there, we can see the nice roundish shape of the bladder, which obviously contains fluid. But again, it being ultrasound, we couldn't actually say whether that's a bladder full of urine or a bladder full of blood. Yeah, but we're hoping it's urine. But what we can see as we scan through the bladder there is a small black area, at least one, and there's another one a little bit higher up as well, where there's free fluid outside of the bladder, and that's not normal. So that'd be abnormal and might suggest there's some bleeding down in the pelvic area. Why might this be useful? Well, it turns out pelvic injury is quite difficult to assess. The QR code I've put up there is for quite a recent paper from Dutch HEMS units that looked at their HEMS physician assessment of pelvic fractures using our traditional ways about thinking about mechanism, but then also, palpating the pelvis for tenderness, looking for abnormal positioning, looking at the shape of it, and so on. And in very experienced Dutch HEMS physicians, they only picked up 50% of considerable pelvic fractures. It turns out these signs are not, massively reliable. So, going maybe back to thinking more about, purely a mechanism-based approach amongst other things, and caution. But Interesting that ultrasound, may be beneficial there in some patients, but obviously not in that patient on the right. So I put the QR code there up for you if you're interested in reading that HEMS paper about pelvic injury assessment. What also could it be used for, sort of outside of our EFAST for trauma? Yeah, there's some other things that it's commonly used for. What about our what to call nutritional overachiever patients? Yeah, those that are very big on the outside. Now we know, of course, it affects lots of things like ventilation and airway, where they're no different on the inside. But access can be very difficult in these patients, can't it? They've probably got quite good vasculature under there because they're feeding a large amount of body mass. They probably have got some quite good blood vessels, but they're very deeply hidden, and accessing them can be quite difficult. And certainly I've been to patients in the sort of supersize area where, even the longest 45mm EZ-IO wasn't long enough. It wouldn't reach the head of humerus, and also wouldn't reach their tibia. Yeah, so I think EZ-IO at one point did talk about making a longer needle, but never did, but can be really, really difficult. Yeah, so ultrasound again can be used either to actually guide the cannula into the vessel, yeah, or just as a way of finding vessels. Sometimes that's enough just to know where the vessels are, but you can actually use it to guide it in. And some of the devices like the butterfly do a biplane thing where you can see both planes, so you can see the needle going down and entering the vessel, which is very clever. So that's possible. But that also enables other things in critical care as well, like arterial lines, invasive blood pressure, nerve blocks, and lots of other things can be done because the metal of the needle of whatever type you're putting in shows really clearly bright white on the ultrasound because it's reflective, so it reflects the beam really well, so you get a really nice view of the needle. So that might be really useful as well. Certainly used that a couple of times. What about in cardiac arrest? We know we're seeing changes in how we do prognosis in cardiac arrest. We've seen a change in JAL-CALC guidelines of resuscitation from 20 minutes to 30 minutes to reflect the survival curve in cardiac arrest. But we know if you look at that survival curve, then survival drops practically to zero by 35 minutes. So we are seeing changes in prognostic thinking about out of hospital cardiac arrest, where actually regardless of the patient's rhythm at the end of 30 to 45 minutes of resuscitation, we've exceeded the guidelines. As long as the patient's had all the reversible causes challenged and it's not a special causes cardiac arrest like hypothermia or something like that, then actually the futility of resuscitation is very, very low. And so ultrasound sometimes has a place, as part of a protocol to make people feel comfortable about stopping resuscitation, particularly in rhythms like PEA, and it can determine that there's no mechanical activity, and that's ultrasound. You can see the electrical activity at the top, but the heart has no mechanical activity, or sometimes just some very little sort of twitching, which is driven by the IV adrenaline normally. Also, it can detect very low flow states. Only a few months ago, we had a patient in cardiac arrest in what appeared to be a PEA rhythm, but then their end tidal went up fairly dramatically, which might be representative of a pending ROSC, and the patient's color improved, and we could get a non-invasive blood pressure on the patient of a reasonable number, but no one could find a pulse on the patient, including when we got to hospital, they couldn't find a pulse on the patient either. So, initially we carried on resuscitation, there was no pulse, but then the patient just continued to look better. So eventually I had a look with ultrasound and the patient's heart was clearly beating. Yes, this patient just has some sort of weird, arterial layout that means you just can't find pulses on. They weren't that large or anything. Some patients are just like that. Or it could be detecting a low flow state. So actually the heart is beating. So the problem isn't that the heart isn't beating. You don't have any pulses because they don't have any fluid in them or something like that. So it enables you to guide treatment as well. So there's definitely a place. And if you look in their ILCOR guidelines, they've put a protocol in there about how ultrasound can be used in cardiac arrest and how we incorporate that without compromising the resuscitation. So it's about getting the scans in the right place, recording them and reviewing them away from the patient. So I think we will see a change in role guidelines over time. I think the JR Calc guidance has been made deliberately more vague. So we may see a change in role criteria reflecting these prolonged resuscitations and the futility at the end of that time. So this might have a part in that as well. So the question that's come up there from Mark, thank you, Mark. What's the risk of delay to definitive care? We're going to talk about how we use that utility, how we make decisions in ultrasound and when ultrasound is useful or not, sort of closer to the end. Is there a challenge in training and governance? Absolutely there is, yeah, as there is always. Yeah, skills learning, can it be taught to non-specialist clinicians? Absolutely, commonly taught in ED departments and intensive care and all that sort of stuff. It's, at the skill level we need, it's away from purely being a sonographer, radiography type device, now in common practice in many places, pretty standard in most emergency settings. So absolutely, it can be taught, in a relatively short time frame for if you want to have limited interpretation skills. Absolutely can be done, but it takes some time to get your sort of eye in, as it were, because ultrasound is very complex. You have to understand a little bit about the physics. So we do physics training. Then you're doing this sort of 3D, 2D. So you're looking at the patient in 3D. You're having to manipulate the probe in 3D, so you need the anatomical knowledge where you're pointing the probe. It doesn't tell you where to point it, so you have to know the patient's anatomy well enough to point the thing in the right place, and we use some markers for that. Then you see a 2D image on the screen. Then you have to come in through your eyes into your head, where you have to reimagine that in 3D, i.e. the patient, in your head, and then look at what I'm seeing, because it doesn't do any interpretation for you as a whole. It's all and so that's the tricky part when you start and just see lots of swirly things, and as you get sort of as you develop experience in it, then you've then got to go through that process. So it's like 3D, 2D anatomy, 3D, and then clinical relevance and hand-eye coordination. That ability to move your hand and look at the screen at the same time and look at the person to see where you're manipulating the probe. I always say it's probably easier to teach ultrasound to a sort of 7-year-old Xbox whiz than it would be to grown ambulance drivers, because they're really capable of that sort of hand-eye coordination and so on. And can we separate the skill of scanning from the skill of interpretation? Probably, and we're going to look about how we might do that in a minute. There might be a way we can do that. But you do require some knowledge of the physics, because the only way you can interpret the image is knowing what the beam does when it hits certain types of tissue in the human body. So you have to have a little bit of physical interpretation. The QR code on this one is a massive list of references I found for pre-hospital use of ultrasound. Everything from training to maintenance of skills to utility, and there's a huge list of references that someone put online. So that code will take you to a massive list of references if that's your thing and you want to look into it more. What was that about calling me an ambulance driver? Yeah, good spot. I can call myself an ambulance driver so I can get away with it. Skill retention is obviously a key in lots of things we do, isn't it? The more complex skills we take on, then skill retention is always an issue. What we have to do is be able to identify stuff where we can find a utility for a device. It can't be a very rare thing. It needs to be something that you use more often. And whether that's a tool then for everyone or for specialist practitioners is really a system thing. If we identify that something would be useful, then it's a system issue to find out how that could be useful and how we can deploy it the best and how we can retain those skills. Yeah. So there is, a whole lot of questions you have to answer there. So some say, is ultrasound something in ambulances in the future? Well, I think my answer is, what I said originally, the 1970s, people said we'd never see defibrillators on ambulances. That was ridiculous. And I think we can now accept that, now we have defibrillators you can throw away. And to say, for someone to stand up and say, no, you'll never have ultrasound on ambulances, means they're completely ignoring the whole of history of how pre-hospital care has developed. Yeah, so I don't think we can never say never. And cost versus benefit is absolutely, but the devices are getting cheaper and cheaper and cheaper, and can be incorporated into other medical devices. And we put a lot of expensive shit on ambulances that's no use for anything. So, I think I think it's not a case of we don't have the money. It's a case of how we spend our money, and what's useful. I'm not saying this would be our number one priority, but I think, it's impossible to say it will never happen. What might affect that in the future? Yeah, so pending at some point, we have the emergency services network, which is going to put 5G connections into ambulances and so on. It's only about 3 years late so far, with a projection there might be another 3 years or something ridiculous. But having high-speed connection to an ambulance makes remote support much more easier, and the ability to live stream it and stream it to a cloud. Most of the ultrasound devices already have something like that, where you can, stream from the device through a Wi-Fi network to a cloud-based thing where someone else can log in and look at it. Yeah, so remote interpretation is already possible. So that would enable us to teach people how to scan, and then get the scans reviewed somewhere else, which would be okay in some settings, but not in all. Some settings you probably need to be able to do both. And there already is such a trial in Scotland. I'm sure I saw some people on there from Scotland. Yeah, there already is a trial running in the Scottish Highlands. Some of the very remote places where the paramedics have been trained to scan people, and because of the lack of mobile data signal, the ambulances, the trial ones, have little satellite dishes on top, and that means that when they want to send the scan, the little satellite dish pops up and just links to a data satellite and can send the scan through. And again, technology is increasing all the time, isn't it? Once we've got 5G on the ambulances, we'll be able to do lots of stuff where it involves streaming information from the patient, to a specialist. In the same way that happens in the NHS all the time currently, where a lot of imaging that's done at night time here is interpreted in Australia by people that are on day shifts. So it's cheaper to get someone in Australia to interpret some form of scan, because it's cheaper to do it somewhere where they're on days. And we know AI is, the latest buzzword, isn't it? If you want to write a university assignment, you can just ask a bot to do it for you, and apparently they make quite a good job. So I've missed out there really in all my education. I had to write stuff myself. It's very disappointing. But AI is progressing massively so, and I think there may be some future in there as well, isn't there? Where actually, we can use artificial intelligence to interpret the scans for us, because what artificial intelligence can do is compare the scan you've taken with millions of scans in its database, and determine what's possible. So there's a lot of stuff in there that AI can do. Think about it, we already do that for ECGs. For years we've had automatic interpretation of ECGs, which is not 100% accurate, I know, by any means, but of course that just uses measurements, and an algorithm. But AI is something that could compare its whole database, and of course it learns as it goes. So the more ultrasound scans we fed it, the better it would get at picking up things. So that's back to sort of Star Trek tricorder, isn't it? Of waving something at someone and it telling you, which bit of them's faulty. Yeah, so absolutely, there's got to be a way forward in there somewhere as AI gets better. So I thought we'd have a little slide from Jurassic Park. Yeah, it's Jeff Goldblum's quote in there, isn't it? When he talked about them, rebuilding dinosaurs from DNA. Just because you can doesn't mean to say you should. With any advanced diagnostics comes advanced decision making as to whether it is of value to do it at all, and whether the results you have are of value. In ultrasound, we have 3 outcomes possible from any scan: positive, negative, and inconclusive. And it's perfectly acceptable to say inconclusive. If you really can't see anything, you just say it's inconclusive. Yeah, because some scans are really hard to do in some patients, and pre-hospital we're doing it usually in a less than desirable setting. So it's perfectly acceptable to try a scan and then just say, no, I tried scanning, but I really can't see anything useful. I can't tell you whether that's positive or negative. It is inconclusive. So whilst we want to maintain the skill, what we don't want ultrasound to become is the latest thing that's overused in pre-hospital care. We don't want it to become the latest cervical collars. Well, hopefully they're sliding out of use. 12-lead ECG, blood glucose, tympanic, all those things of the future, where everyone gets an ultrasound, regardless of the fact they've only rang up because they've got a sore toe or something. Yeah, so it's about using it appropriately. And for that, maybe we need a set of guidelines. So these are the 7 rules of critical care ultrasound from Dr. Justin Barrow, who's a famed Australian international author of ultrasound texts. Yeah, and these are some of his rules. Yeah, so sort of resus only for the pre-hospital use. Really, we're only really using it for stuff where we're really concerned about important parts of the human body in the emergency setting. Context is absolutely key. Yeah, it's really, really important we have the clinical context of what we're doing. Yeah, like all diagnostics, yeah, a diagnostic is worth nothing on its own. It's like if you show someone a 12-lead ECG and go, "What's that?" If someone gave me a 12-lead ECG and say, "What's that?" I'd go, "Well, what does the patient look like?" Yeah, 12-lead ECG is worthless without the patient information. Because I've got a paramedic I used to work with who has massive ST elevation all the time. Yeah, if you do a 12-lead ECG on him, but he's not having an MI. Yeah, he doesn't look like he's having an MI. So you've got to have some clinical context to it. The scan in itself doesn't tell you everything. What happened to the patient? That might tell you what type of fluid is you're seeing. Yeah, what's the mechanism? What's the history? All those things are relevant in all the diagnostics we do, as I'm sure you'd agree. Only ask questions you can answer. We can't just take our ultrasound probe and wildly go scanning someone all over to try and find out what's wrong with them. We need to have a reason for our scan, and we need to ask it a question that it can answer. Yeah, if we're just randomly looking for stuff, it's not going to be helpful. It's just going to eat into patients' time, isn't it? Remember, a scan is only negative or inconclusive at the time that you do it. A bit like doing a 12-lead ECG that's normal. 10 minutes later, they might have massive ST elevation. Yeah, so a scan is only normal at the time you scan it. Yeah, and may need repeating. When in doubt, we said about our inconclusive exams, always be a clinician. Yeah, the ultrasound is not a clinician. It is a tool. Yeah, it is a thing that allows us to do a diagnostic test with a question and come up with some information to support our clinical decision making. It's not a clinician. And I think the point they wanted to make that end was, a fool with a stethoscope will be a fool with ultrasound. Yeah, just because you have got a fancy bit of technology will not make you a better caregiver. Yeah, that's part of a much bigger picture, isn't it? So anyone's interested in ultrasound learning? Yeah, we were one of the first places to set up a sort of a series of ultrasound courses, which we run in 4 different countries now. I see a lot of places are starting to do it now, but I'd like to think we were sort of first. So yeah, if you're interested in ultrasound training, have a look there, and you can see where we deliver it in other countries of the world as well. And these are, pre-hospital courses, so they're designed for the setting that we're working in. And finally, we get to the end. So many thanks for listening, and we'll get through some questions in a minute through the Q&A chat box. And I'm hoping to see you next month on the 1st of August. We're going to talk about decision-making in pre-hospital care. Yeah, it's not black and white. There's no always and there's no never. I teach to some undergraduate paramedic students, and I'm not sure they like me, because sometimes they ask me questions like, if we go to this, what should we do? And my answer to them always is, well, it depends on the circumstances. And then they pull a face at me and I go, that's why you're here for 3 years. You make the answer when you've got suitable amount of knowledge. Yeah, it's not, pre-hospital care is a huge area of grey. To have some decision-making tools to help us, and understanding decision-making can be really, really useful. So that's what we have next month. Andrew, are you there?
I'm always here. and that's why I'm looking for a replacement, Jamie, because I'm always here. This is like in fact, me and you could just have our own little show, the Jamie and Andrew show.
That's true. Yeah, I'm not sure.
Just talk about anything and everything. In fact,
Yeah.
it would be
Oh,
fabulous. We'd have an amazing audience, wouldn't we? We'd have to get you some better lighting though to bring some colour out in your cheeks, I think.
Oh no, yeah, I don't look like Rylan like you.
Oh, the cheek, honestly. Anyway, if you want to leave Jamie some positive feedback, I've just put his feedback links in the chat for you to have a look at. So please do that. Jamie, while you quench your thirst with some water, I'm just going to share my screen for a second, and then you can dip into the questions and answers if that's all right. So I'm just going to tell people, did he just say Rylan? He did, didn't he? Shocking. Anyway, hopefully you can see give me a thumbs up if you can see my screen. Yep, he also does comedy, Jamie, as well as education, so you can sign him up whenever you like. Please do leave him some genuine feedback, because Jamie can use that ultimately for his own CPD, and so you don't need to mention the comedy sketch in there, because he does try aimlessly to outwit me, but there we go. I didn't mention this before, but you know we always rely on positive or neutral feedback, so please do leave us some genuine feedback on Trustpilot, Google reviews. Fabio has asked me again if you use the Android or the iPhone app to please leave us a review on there. And then Fabio tomorrow is going to go through, and he's not going to just pick 2 winners, he's going to pick 4 winners. So we are going to give away 4 £25 Amazon gift vouchers tomorrow at noon. So please do leave us a review between now and tomorrow at noon, and then you'll be in the chance to win 100 quid worth of Amazon vouchers, 4 of you. £25, you'll definitely buy a book for that. In fact, I'll tell you whose book you will buy for that. Dr. Caroline Leach's new book, and she's going to be telling you all about it, no doubt, on the 6th of July. But you can join us on Thursday this week, where I'll be back again, surprisingly, covering the new UK concussion guidelines. The following week, I've got Caroline Leach with the C Assessment in Trauma, and Caroline just released the new book with some other celebrity speakers who will be joining us shortly. So please do join Dr. Caroline. And then, of course, we've got our amazing mental health practitioner, Stephen Marks, on the 11th of July, covering all things organic psychosis. And if you are keen to build a portfolio that is fit for practice, a portfolio that will be with you for the next 20 years of your amazing career, then please do join me on the 19th of July for a CPD Mill portfolio building webinar. I'll be in the Isle of Man that evening, so it'll be not from here, from the fabulous studio. It will be from a hotel, sat on my own, drinking a Capri Sun probably, sat on a hotel chair, wrapped in a hotel towel, and everything else that goes with it. So, Jamie, questions and answers, are you ready?
I'm ready, thank you, Andrew. I've had a quick look. So cool. So we've got a couple of questions to go through. If everyone's just got a couple of minutes left. So someone, an anonymous attendee, but thank you for the questions. Do you think price point is holding back the wider POCUS deployment? Like everything, but as we said, the prices get cheaper all the time, and I'm no doubt will continue to do so. Like everything in pre-hospital care, we know medical things are expensive. Working in a remote area and access to critical care advanced support is just not possible in a reasonable time frame. And that does really have a place, doesn't it? Once you get further away from help, then this diagnostics can be very helpful. I've certainly deployed ultrasound when I was, it'll come up in my talk in a couple of months' time about remote medicine. I've a past work in sort of remote medicine, and certainly we carried ultrasound when we were in Mongolia for 3 months working for Land Rover, where there probably wasn't another ultrasound machine in Mongolia then. So having that sort of remote place where you can do advanced diagnostics is very useful, because their evacuation comes with a huge amount of risk and cost. So making decisions where to evacuate someone or not, and then the speed you need to evacuate them, how urgent it is massively helpful in a remote place, particularly if you're somewhere where evacuation is only possible by daylight. It takes a day to get evacuation to you and all that sort of stuff. So hugely beneficial. So in a remote place, very much so. And that definitely, as long as you have access to a BGAN or something, so you've got a satellite link, and again, that's very cheap now. Satellite data is dirt cheap. So as long as you've got something like a BGAN, which has got every sort of port on it, you can just plug in and whiz the video clips off to a remote person to review, and that's commonly done on offshore platforms and that sort of type stuff. Someone else asking, in obese patients, if you used it to find veins, it's use the venoscope to find veins, specifically to find veins. So I'm not 100% sure what the question is, but the ultrasound will find veins, quite nicely. You can find the vessels, and then you can use the ultrasound probe to determine whether they're arteries or veins by what happens when you put pressure on them. So you can identify the veins, and then you can actually use the ultrasound probe to guide the cannula into the vein, in one of two planes, or if you're using a butterfly, both planes at the same time. It is very, very useful for IV access in difficult patients if IV access is required and IO isn't an option, because the patient is not in the criteria for that. Another question for offshore, definitely. I've worked in parts of the world where medevac would have cost us 40,000-50,000 pounds to get someone medevaced. So having diagnostics that can stop that happening, is obviously a massive benefit and a huge cost saving, and probably also the right thing for the patient, because those things come with risk. That, I think, Andrew, is it. One last thing on the bottom there, using Rapid to improve nerve blocks. So yeah, not sure about the Rapid 2 trial, but definitely things like fascia ilia nerve blocks is far easier to do on ultrasound than by a anatomical based technique, because you can see the vessels and you can see where the tip of the needle is. So it makes it super lovely. Back to you, Andrew. Thank you.
Jamie, I can only say that you've probably covered every question in your in-depth presentation, and that's why we don't have many questions. So, again, thank you so much, Jamie. I will be in touch, because I think you could do my job, Jamie. I think you could be me.
Well, I'd have to shave some hair off, and whatever, but I'm willing to do it for you.
You can't help it, can you? Honestly, I think you'd be fabulous. You'd be fabulous. And so maybe we'll get some branded tops and uniforms as well, and make ourselves look like proper presenters and all that, facilitators.
Be professional.
Maybe we'll just get some CPDME dressing gowns.
You did promise me one. I've not had it yet.
Yeah, we're just struggling for sizes at the moment. They're only coming in small and extra small. So I'm afraid.
What are you trying to say?
I'm not saying anything apart from we've got small and extra small. Clearly, the manufacturer sent the wrong sizes. They must have misinterpreted my selfie.
I see, yeah.
Anyway, ladies and gents, thank you so much for joining me tonight. Jamie, thank you so much again for a fabulous presentation, and we can't wait to have you back next month. Ladies, gents, team, people, members, non-members, thank you so much for joining us tonight and giving up your time on a Tuesday. If you are at work, please stay safe. You are doing an amazing job. Be kind to yourself and each other. If you are at home, kick off your slippers, maybe throw your dressing gown off your shoulders, maybe go and pour yourself another drink. Enjoy the rest of your evening. Thank you so much for your continuing and ongoing support, and I'll see you Thursday. Take care. Thanks, Jamie. See you later.
Thanks, Andrew. Thanks, everyone. Bye now.